get started. So hi everyone, I'm Lahira, I'm one of the anaesthetists. I'm actually presenting this with Jason. So Jason's kindly put together a multimodal analgesia tube, and I'll hand it over to him. He's one of our anaesthetic registrars. And very, very much in the space of pain management, because these guys do all of our pain rounds for us, which is something that most anaesthetic consultants don't like doing. So thank you very much, Jason, and everyone else.
Well, I'm Jason. I'm one of the anaesthetic registrars. I'm coming up to the back half of my training now, and like you guys, I went to Melbourne Uni, so I was postgrad, and then before that, I was a neurophysiologist and a pain researcher, and a pharmacologist, and then sort of jumped ship into medicine. But even though I probably have a decent foundation for this sort of stuff, still feel pretty much in my infancy, like there's a long way to go, and you just don't stop learning, really. So ask as many questions as you want. Lahira is there to answer questions that I don't know the answer to, and we'll see how we go. So today the focus is going to be on acute pain. So that's pain where there's still healing involved, and we're going to focus on the non-opioid analgesias, and the other focus is going to be on you guys. So tried to take a lot of the complex physiology, pharmacology, and put it into a package that'll be targeted at you guys and make you pretty good independent describers with a lot of the pain stuff when you're interns. So you'll be able to smash it, really. So
like Jason said, we want to make these shoots so practical. As soon as you get out first day on the job, if you keep these slides, these notes, we want you to be able to do exactly safe prescribing at the end of this. So that's good. And also any questions, I'll run the chat. So just type questions in the chat, and it's great having two of us, because then we'll try to get more content out to you during this time.
Yeah, so when we're on pain, covering pain, or when we've got the anaesthetic in charge phone and we're receiving these referrals, this is really common sort of situation. We've got someone with a patient in a lot of pain, they're going up and up on opioids, and they're not winning. The doses get pretty high, things aren't going very well. The patient struggles, the nurses get really distressed and they end up putting that onto you, trying to get you guys to fix it. Families get angry and you feel really flustered. And things feel out of control, but if you use sort of some of the information you get today, you'll have a lot you can pull out of your back pocket, and you'll understand how you can sort of take control of these situations and basically do the same things that we do to resolve these. So this is what we're going to go through. So we've got some definitions and physiology of pain, and I'm going to go through a really nice overall approach to summarize the types of pain, and then we're going to build up a drug arsenal so that you guys will know, a decent amount about a few drugs and know how to prescribe them really well. And then we'll do a bit of a summary and we'll use it for some clinical situations. So here's the ground rules. The first one is essentially the basic assumption, which hopefully you guys have heard before, but we're all intelligent, capable people who are trying to do the right thing. And it's a very safe environment just to ask any questions you like, for all of us to make mistakes and learn from, and without any judgment. And then this is another one I particularly like, is that it's very applicable even when you're a consultant of 30 years. You just remember that the stuff you already know might prevent you from learning. And when we're talking about things, paracetamol, that seems really easy. If you step back and show a bit of humility, you'll be able to get even more out of it. So any volunteers? What is pain?
I guess you could say it's the body's sensation of stimuli that we think might be damaging, and then the perception of them centrally. So it's like a two-part thing, I guess.
Yeah, nice one. Can you tell me a little bit more about that perception bit?
Well, I guess that can be modulated, and that changes depending on a lot of things. But I guess that's how we interpret the signals that are coming from the periphery. I don't know.
Yeah,
I think it's very much like pain. I remember learning in undergrad is a subjective experience, and sort of an emotional experience, as well as being potentially physiological, because it could even occur in the absence of a stimulus. It can actually be just the threat of a stimulus.
Yeah, nice one. Super impressed. That's awesome, guys. When I'm on pain rounds and I have med students in 4th year, and sometimes some junior doctors can't pull that out. So that's excellent. And this is the official definition. I'm not super surprised when people don't know it, because it is hard to wrap your head around. It's got sensory emotional experience, real or perceived tissue damage. It's a little bit difficult sometimes to wrap your head around, but that's impressive. Then we've got the nociceptive pathways, and I could probably sense some of you have a bit of internal anguish seeing this stuff from 1st year, but essentially we've got the A delta C fibers coming into the dorsal horn, then it comes into these, the laminae 1 to 7 goes on to nociceptive specific and wide dynamic neurons. Some of them come up and down a level to those lentitia tracts, crosses over, goes up the anterolateral tract, and then it goes into these 3 different pathways, some going to the pons and the midbrain, some going to the medulla, some going to the spinothalamic tract and the somatosensory cortex. And it's hard to grasp what does all that actually mean. And a lot of the time when you learn it, they put a lot of attention on the somatosensory cortex, your sensory homunculus, where the pain is and that sort of thing. But soon you'll see that doesn't really matter that much. And then, as you guys just mentioned, that there's a modulatory tract, the descending pathways, and then sometimes even throw in this, this gate theory part of perception of pain and how to block it, which is contested, but it's pretty complex, difficult to remember, even harder to put this into clinical practice.
Quick question, Jason.
Yeah.
Do you use this in clinical practice? Does this knowledge ever come up in clinical practice?
It does for me, and I've learnt this stuff so well that I've basically built a very simplified model of it, which I'll go through with you guys. And it's the reason it comes up in clinical practice for me is it helps me remember what each of these pathways actually do, and then it helps me realize, like, is this a problem with like the emotional pathway? Is this a problem with the more autonomic pathway? Is this a problem with the pathway going up to the somatosensory cortex, which it never is, but it helps me to like put that into a bit of perspective and where I want to target. And then the descending pathway, the modulatory pathway, it reminds me of how I can target that. But having this in your head is too complex. You have to simplify it and then put it into a clinical context of what does it actually mean.
I find that it helps me to know the receptors that I want to block, or the pathways I want to block, and that reminds me which agents to use and where it might cause a problem. I mean, when I think about the COX-2 inhibitors or the COX inhibitors, aspirin, I think such a complex pathway gives me a lot of information about what I need to block, but then it reminds me, I've got to be worried about the other stuff, which we'll go through, like GI bleeding, etc.
Yes, that's right. And if you're an anaesthetist, these are from my exam, but you'll learn like the pharmacodynamics, kinetics of drugs. You'll learn the side effects, their actions, onset times. You'll learn a lot of their chemistry. You'll learn different pathways. You just keep learning and learning all this detail. And if you try to use all of that and then you use those complex pathways, you're left pretty confused. So what we see is an alternative approach in some doctors, which is the pain ladder. Does anyone remember the pain ladder? This one's a pretty simple one.
If you don't remember it, just have a guess.
Okay, I'm going to take a guess. Is it like a stepwise approach to pain management? Like this drug and then this drug and this drug?
Yeah, that's pretty much it. The World Health Organization, it's a World Health Organization thing. To be honest, I don't really love it. It doesn't take the type of pain into account, the physiology, and it puts opioids in a position of superiority. So this is sort of it. They say non-opioid, weak opioid, strong opioid. Weak opioids are a pretty contested term as well. And, once you start practicing, more about drugs, you realize that opioids aren't superior and they carry a lot of harm with them, and you get more out of using the other drugs.
I find the
It's
real
also pretty
useful.
boring.
I find the really useful thing about knowing the terms multimodal analgesia and analgesic ladder is that you can impress people with it. So often the right answer to a question is a cliche. How do you treat this patient's pain? Well, I'd use a multimodal approach, or I'd approach it with the stepwise approach of the ladder. Those are important things to know because our culture tells us to target those things as words to use, not necessarily, but also to know that there's so much around that, and that's what we'll be teaching, the actual detail around that.
Nice one. And ultimately, it's like the analgesic ladder is a bit boring. It makes opioids happy because they get a position of superiority. Makes the orthopedics and surgeons pretty sad because their patients can get the wrong drugs. So how can you be a really boss intern with your analgesia management? And this is sort of the summary of my tips of how you can smash it. And if you know the key physiology, if you have like a really good approach for it, if you have an arsenal of analgesic drugs that you can pull on, a few in your back pocket that you can use when you need them, and then know when to ask for help, and having all those things you feel knowledgeable, it actually makes you feel pretty good, then you'll have all these benefits, and importantly, you'll have a functional patient, have good analgesia, and then they'll have good recovery. So this is the key physiology. So if we take that definition, the really important bit of pain is that it's a duality. There's the sensory aspect to it, and then there is the emotional aspect to it. So the sensory aspect is, essentially where the pain is. So if you'll know that you've got pain in your hand, but it's not necessarily an unpleasant feeling. The more important part is the sensory bit, the emotional bit, sorry. This is the bit that makes it feel unpleasant. This is the bit that makes it distressing. And this is the bit that if you think about and you target, then you get better pain relief. If we put that into the physiology, we've got this pathway number one, the purple one. If we were to zap, the end of that pathway on the somatosensory cortex, say where the hand is, you'll have, a sensation of touch in your hand. It won't feel like pain. But if you look at the second pathway here, which is the spino-mesencephalic pathway, if you zap that, you're going to have a really bad time. And I have zapped it. Before I did medicine, I did electrophysiology and wholesale patch clamp recordings and zapped it, and it's not a fun experience. The third pathway, really its main role seems to be an autonomic stuff. So if you stimulate this stuff, you increase your heart rate, your blood pressure goes up, you sweat. So if we simplify the physiology, it's just the sensory bit, the emotional bit, and if you can keep in the back of your mind that, I'm trying to target that emotional aspect to it, you get pretty good pain relief. And harp on about it, but you see people who are distressed or people who have anxiety, people who have depression. If you step back and you observe the volume or intensity of pain those people get, it's much worse. And people who have long-term pain, they end up getting anxiety and depression. It's really the bit to sort of cement in your mind. And then we mentioned already, but there's a descending pathway is the last thing. And the good thing to remember about this is it's a noradrenergic and serotonergic pathway. So if you've got drugs that are acting on noradrenaline, acting on serotonin, you can really reduce the volume of your pain by getting these things. They're a nice type of pain relief. They work on all types of pain. And what's often not shown is this pathway just in the middle here. It's in the pons. It travels up to the amygdala as well. So if you're inhibiting that pathway, you're inhibiting the amygdala, the pain in the amygdala, and you're going to have less stress with your pain. So you've put the physiology to the side, remembering, that it's a duality, sensory, emotional. The approach to really make you smash pain, and this is from going on pain rounds with lots of experienced consultants, is there's a bit of a setup in that you set the expectations for the patient and you set goals. So where do you want to get to? What sort of destination do you want to be at? And how are you going to get there? And it's not really an emphasis on how bad does your pain feel. It's about, can you reach these targets and expectations? And looking at the assessment of pain itself, it's really helpful to be able to work out what type of pain it is, which we'll go through, And then the pathology is helpful too. Like it's involved in inflammation, is involved in capsular pain of the liver, that sort of thing can help determine your drugs. And then thinking about what is the pain like at rest, and then what's it like with activity. You'll find that if you ask people about their rest pain, they often don't have any pain when they're resting. They're actually comfortable when they're resting. It's when they're doing activity. So you really want to target your pain relief around activity, which we'll go through later. And then again, functional limits. You're trying to work out where are they limited with function? How can you get them to the functional level they are? And then you're stepping back and you're thinking, what's the degree of distress or emotion in this patient? What can I do to reduce that? Because that's going to really decrease the volume of pain in people. And then assessment nowadays of opioid risk as well, because we're recognizing that a lot of people are getting into lots of trouble with the opioids they're using. The treatment, using regular multimodals, and then using the PRN medication, the sort of breakthroughs to get them to do those functional tasks with active pain. And then finally, you sort of want to get out of there and de-escalate, so not leaving any opioids hanging around. All right, so just quickly, who can tell me some, some functional aims that we might use in the hospital setting?
Getting out of bed, moving around.
Nice one, exactly. So they're the sort of things that on a, when we talk to the patient, these are the things you need to do to get healthy or to get better and to go home. And we're going to use these drugs to be able to get you to, mobilize, get out of bed. And then the other common one is to make sure that they can deep breathe and they can cough well. And that's really what you're going for. And then setting goals, it's similar. The goals are similar, and I like to more and more include the patient in this and destination set as well, and just check, where do you want to get to? Are you trying to just get back home? Are you trying to, go back to running your marathon? It's not hard stuff. You'll notice that in this, in your goal setting, in your functional setting, I haven't really got anything on here about pain scores or pain as a target. So in your mind, what are the pain scores? What are they useful for?
To know how much treatment they need for it?
Yeah, it's an interesting thought. I don't use it for that so much. I will use the functional thing as how much treatment they'll need. I do ask about pain scores, but someone will tell me a 10, they'll tell me a 5, they'll tell me a 3, and I don't, read too much into the actual number they give me. I still look more at the function. If they move out of bed, I'm pretty happy, and I won't really escalate their pain relief.
Is it more just the change indicate some sort of improvement? So we're just looking for change, really, huh?
Yeah, it's great. It's perfect. It's really good just to look for change for me. Like I'll see someone and I'll say, what's your rest pain like? They'll say 6. What's your, or 6 is a bit high, but what's your rest pain like? They might say 2. What's your active pain like? They might say 8. I'll note that. And then I'll watch them do a functional task, deep breathe, cough, mobilize, and I'll institute some pain management. Then when you go around the next day, you say, what's your pain at rest? What's your pain when you're active? And just see if you've got an improvement. And then even if they don't, give you a subjective improvement on that. If their function has increased, you've made an improvement. They're still useful, but I caution against setting it as a goal, because you'll experience people, particularly people who get distressed with pain, that they'll always report 10, and you'll keep going up on your pain relief, and you'll start to introduce a fair bit of harm, and you'll feel like you're not winning. But if you step back and you look at, well, are they getting better? Are they more functional? And are they improving day by day? They will be. And then the last point, on this expectation sort of slides is it's helpful to be reassuring, and it's helpful to be calm. So I like Liverpool, and Van Dijk is Liverpool's reassuring and calm player, and he's injured at the moment. So Liverpool are losing all their games. So if you can, despite all the anxiety or stress in the room, if you stay reassuring, stay calm, you set the functional aims for the patient and the goals, and as well as the nurses or the other doctors around you and what you're trying to achieve, and remain calm, that really makes a big difference. Which is pretty much what we've talked about. So can anyone list some types of pain?
Neuropathic.
Yeah, nice one. Nice one, big one. And what are some other types?
Inflammatory.
Yeah, nice, nice. Yeah.
Like chronic versus acute.
Yeah, that's a good differentiation. I've focused on acute pain here, but it's really important to recognize when you're treating chronic or persistent pain versus acute pain, because more and more you'll find that your drugs aren't really going to be as helpful, and the low-lying fruit comes from other things. Yeah, what other? What was that one?
Mechanical pain one?
Yeah, I put mechanical pain in.
Would you say somatic pain as opposed to like neuropathy?
Yeah, nice one. That's really good. So I might move on to mine now. So I put them under some umbrellas of neuropathic pain, somatic pain, and visceral pain, and I just keep them under these simple umbrellas. So somatic pain is going to be mechanical pain or soft tissue pain, incisional pain, inflammatory pain. They've got all the same sort of quality: sharp, dull, ache, throbbing. There's redness around them, those sort of things. And then I'll class stuff into visceral pain. So this is when you've got essentially organ involvement, and generally the quality of these are dull. They can have like the referral pain, and then nausea, vomiting is not uncommon with them. And then we've got neuropathic pain. There's a fourth type of pain that's sort of recognized now called neuroplastic pain. It's just essentially when you've got plasticity involved and you start to get the allodynia, hyperalgesia, but it's probably more in the chronic pain realm than the acute. And these are good to know. Often they're obvious because, your patient's had surgery, so they're going to have somatic pain from the incision, and they're going to have visceral pain from where their gallbladder got taken out. It's not rocket science, but sometimes you're not winning with pain, and it helps to be like, I'm treating the wrong sort of pain, or I'm using the wrong drugs for this type of pain. So
Jason, I was going to ask you about that. We mentioned, acute pain. We mentioned pain scores and functional state.
Yes.
And I think it's really practical in the sense of, what interns will get most commonly in terms of neuropathic / chronic pain will be the patient that presents with lower back pain that they've had chronically forever. And now something's happened, it's maybe aggravated, and they come into the emergency, and then you'll be asked to maybe treat that either as an intern, resident, a surgeon, even as a pain registrar anesthetics. And how would you then use the pain? Like the pain score is always 10, no matter what you do. And how do you then treat that?
Yeah, the back pain's always the classic, and it's difficult to manage. And a lot of it comes from, I've got a pharmacology analgesic sort of arsenal I use for flare-ups of back pain, which doesn't involve many opioids, but a big part of it for me is setting the expectations and a bit of pain education with the person who's having their flare-up. So, talking about the flare-ups, that they're not uncommon, telling them that it gets better, and the things that makes it get better are going to be those functional goals. So, mobility within your limits, make sure you ambulate, don't stay in bed, go backwards, and then having a discussion about pain relief that we'll use for a flare-up, but then you're not going to be on it in between a flare-up because it'll do you harm. But at the end, I can go through my little recipe that I'll use in back pain.
It's almost unsatisfying. I'll not be able to get this pain score less than something high like 7, 8, 9, 10, but I will treat with the setting expectations, a multimodal approach, optimizing everything. And at the end of the day, all we have is functional status to get the patient back to a livable function. So,
and in that setting, I rarely bring up pain scores because it doesn't help in that setting. So I generally don't bring it up.
Jason, you know how you said before neuroplastic is sort of this fourth type of pain, if you want, but could you think of it, if you wanted to, as sort of a subtype of neuropathic?
Yeah, you could, but you do see people who have long-term somatic or visceral pain, who end up getting these features of neuroplastic pain. And essentially what happened is you get some changes in your transcription of various proteins. Your NMDA receptors are a bit different. You get upregulation, downregulation of things, and ultimately it means that people have increased volume of pain to lesser stimulus, and they get pain in the absence of any no longer actually having active tissue damage, and then they get allodynia, hyperalgesia. It's more common in neuropathic pain, but you do see it in the other types of pain too, when it's persistent. And it often comes with anxiety and depression because you're constantly stimulating that pathway that we talked about before, and your amygdala is getting hammered.
And also, I'm not at all belittling, like I completely putting it out there. I'd believe a patient if they said it was getting worse or that
Yes.
like that. But could it also be if someone suffered from chronic pain for a long time, 5-10 years, it may potentially be psychological, the hypersensitivity or things like that?
Yeah, I just take people at their word really, and because I'm a physiologist at heart, I put it in a physiological context. So I think about the pathways and the things like that, and that when they're more distressed, when they have a bad day, when something contextual happens in their life, their volume of pain is going to go up because that pathway is going to be working a bit harder. How you approach that might not be with drugs, might be with getting on top of their anxiety and depression, looking at some of their social situations, trying to help them out with that, giving them a bit of empathy, a bit of education. It's antidepressants and things like that. If you ask the question to a rehab physician in chronic pain, or if you ask it to a psychologist or a GP, they'll probably give you a more psychological answer to it. But,
yeah, great. No, so that answers my question. You sort of like a physiological approach, but that doesn't necessarily always equal drugs.
Yeah, no, not at all. No, not at all. I'm pretty, science-minded, and I like knowing the physiology of even why people, feel emotions, not necessarily the psychology of it. But the treatment's the same.
Thank you.
Yeah. No worries. So this is your guys' turn. What pain relief do you know? You can throw pain relief at me, and then we'll make a bit of a list and we'll start going through them.
Paracetamol.
Yeah, nice one. Good one to start on.
So you have like anti-inflammatory drugs?
Yeah, nice one. Good. Yep, and non-steroidals.
Opioids.
Yep, got the opioids. They're on the list.
Aren't they the ones that are cannabinoids? They're like new or novel.
Oh yeah, didn't include the cannabinoids. I hate anesthetizing people who smoke weed, so I don't know what it's going to be like anesthetizing people who take the cannabinoids. We'll see.
I'm not sure if this is too niche and too specific to a pathology, but DMARDs.
Oh yeah, nice one. God, nice one. I didn't include those ones either. Yep, the DMARDs, and a good one. That's the treatment of the underlying cause, which will reduce pain. So that's a good thing to think about, is treating the cause and not just treating the pain.
I think for neuropathic pain, there are like gabapentins and those kind of.
Yeah, nice. Yeah. Can anyone think of some other things that would work on neuropathic pain?
It's like nerve blocks, but I don't know what you use. I think it's like a lidocaine or something in like the nerve root.
Yeah. Local anesthetics. That one's good. Yeah, nice one. And you can, as Lahira was talking about before, you can think about it in the pain pathways and, receptors, if you can recall them. And we've said paracetamol, non-steroidals, which are going to work at the periphery, at the nociceptors, and paracetamol, a few other places. We've got local anesthetics that'll work at the nerves themselves, the gabapentinoids that are going to work at a receptor level. And then, so what do we have so far? Paracetamol, non-steroidals, opioids, gabapentinoids, local anesthetics.
Ketamines. Ketamines.
What was that one?
Ketamine.
Yeah, ketamine. Yeah, nice one. You guys haven't said my favorite yet.
Fentanyl.
Put that one under opioids.
Morphine or something.
Yeah, opioid again.
Aconitide?
What was that one?
Aconitide, it's a conotoxin.
Oh, conotoxin. Yeah. I read about that one a while ago. I've never seen it. But yeah, a novel conotoxin medication. I think it might go into intrathecal space from memory, but you might know more about it than me.
I think you're right. It does go to the intrathecal space.
Yeah. I'm going to give you my favorite one, clonidine. Clonidine's my personal favorite.
Clonidine, did you say?
Yep. And then there's one more that's pretty common that generally people reach for before an opioid. People get a bit worried about it with giving it with antidepressants.
Would you say alcohol? Does that count?
I'll scratch that one. All right, let's have a look at the list that we've got here. So got paracetamols, non-steroidals. Tramadol was the one I was fishing for. Tramadol's, really pretty helpful drug, which we'll go through. Clonidine, which is, my back pocket drug. And I'd be pretty happy for interns to be using clonidine if they know how to use it. So we're going to go through that one. Your non-pharmacological stuff I put in like my little arsenal. And this is like when you're not the really low-lying fruit. If you put in some of the non-pharmacological strategies and some of the other tips I'll give you at the end, with the drugs you've already got, it makes a big difference. The opioids, and then in orange here, I've got the gabapentinoids and the antidepressants. These are ones that, as interns, they'll be in your, your little arsenal of drugs that you'd want to give, but they're thoughtful drugs. I generally get advice for giving them, and even now I don't necessarily start them unless I've got continuity of care and I'm having a discussion with the GP or some of the other teams involved. And the blue ones here are the ones the anaesthetists are going to come give when the anaesthetists are involved. And we probably won't go through those ones today because you guys are going to get exposure to those ones in other tubes. So this is just a slide on doses. People get really anxious about doses, particularly coming internship, and everyone tells you don't worry, and you don't have to worry because you get exposure to it and you work as a team. You've got people to ask, the pharmacists, experienced nurses, and your peers, residents, registrars, consultants. But there's some really good places to look. A lot of the hospitals have electronic prescribing now in care sets, so they'll give you a dose and you can decide as a prescriber if that's appropriate. The AMH and the TGA probably have the most reliable sources for textbook doses to give. And there's clinician health channel apps. And then I haven't used this resource, but Lahira is a big advocate for it, and I hear heaps of people using it. But it's the Frank Sheehan app, or the Frank Shan app rather, which is a Royal Children's Hospital guideline. Do you have any input on Frank's app, Lahira?
Yeah, so I think it's what so many of us use. It's got the pediatric dosing in all the different routes, as well as adult dosing, and a lot of us go to that as our first resource. So just to know that sometimes your drug dosing will be different based on different resources, but so many of my colleagues over time have done, so Frank Shan's drug doses as the first app, and the other one is Medscape, which has a medication part of that as well. So those are the two apps that I use just constantly. And again, we don't care you don't need to memorize stuff these days. You just need access and knowing where to go. So yeah, those would be the two apps I'd choose.
Yeah, I mean, that's a good learning point for me. I might download some of these apps. That's fun. All right. So let's do paracetamol. So I'm going to get you guys to start. Can you guys, you can tell me anything you know about paracetamol. You could use the headings here and tell me what you want to contribute, and then we'll go through it.
We always get told that no one really knows the mechanism of paracetamol, and we just keep using it because it works.
Yeah, nice one. Yeah, I think that's fair. We're gonna, you don't really have to know the mechanism of paracetamol because it's unclear. And in the next slide, I'll show you some of the proposed things. I haven't looked at the research lately. Maybe it's clear now, but it's the teaching that it's unclear. What about, we went through those 3 types of pain. What types of pain do you think would be effective on?
Somatic.
Yes. Yep. Is it going to be helpful for visceral pain?
Maybe.
Yeah. All right. We'll go maybe. And what about neuropathic pain?
Unlikely.
All righty. And this is these next 2 are important ones for me. I can pick up the difference between someone who's prescribed well and not well based on these ones when I'm getting referrals for pain. So are you going to give it to everyone? And are you going to give it regularly, or are you going to give it as a breakthrough drug? Who wants to have a stab at these 2?
I think you shouldn't give it to people who are likely to have low glutathione. So like people who are alcoholics, things like that, because it can, or people who have liver issues, because it can be quite hepatotoxic.
Yeah, good answer. And, do you want to elaborate on that a bit more? This is like
from memory, the liver breaks paracetamol into an active component and then makes some toxic byproducts, and then use glutathione to clear away the toxic byproducts and make them into less toxic bits that can be excreted. And so if you are alcoholic, which uses up glutathione, or you don't have good nutrition, so you don't have enough glutathione, then you won't be able to appropriately get rid of those toxic byproducts. And so the toxins will essentially build up in the hepatocytes and kill them. And so you get a lot of I think you get death of necrosis of the bit around the center of the, that might not be correct. I
know. I'm really impressed. Really impressed. That's good knowledge, good memory. Definitely, at your stage, I would have, been told that and forgot it 3 seconds later. Very impressed. Are you going to give it regularly? Or are you going to give it as a breakthrough?
Regularly at small dose. If you're doing small doses for people who you think they should be fine because they don't have hepatic issues, it can be given at low dose or mildly, I think would be fine.
Yeah. All right. Well, let's go through this, and I'll give you my thoughts on this based on the pharmacokinetics and pharmacology and the pain pathways and whatnot. So mechanism, you're right, not entirely clear. People say a COX-3 inhibitor. There's other suggested, mechanisms. The central prostaglandin synthesis. People have come up with this with the idea of how it stops fevers, and then some serotonergic activity, which is if we think about those descending pathways and we think that's a good drug, and inhibit the reuptake of serotonin, again, descending pathways, good drug. And I don't know what the 4th one means, blocks peripheral generation of nociception doesn't mean anything. But I guess that means that it works peripherally, even if there isn't a mechanism behind that. So you've basically got a drug, unclear exactly the mechanism, but the suspected sites of where it acts or the mechanisms act all over the place. So we've got some activity at the level of the brain, we've got some activity at the spinal cord, and we've got some activity peripherally. So it works on all types of pain if we think about it in that regard. And a nice thing about paracetamol is because it works on lots of different types of pain, we give it intraoperatively IV, and when you take away the subjective aspect to it, we see people's heart rate go down, their respiratory rate go down, tidal volumes drop, so the minute ventilation's lower, the blood pressure goes down. We get that, response you'd expect to, a good pain relief. And you look at the literature, you get a 30% reduction in your use of opioids when you're giving paracetamol regularly. Like it's a good drug, even though it doesn't have much of that subjective, aspect to pain relief. It functionally and from a opioid reduction perspective, it kicks goals. So are you going to give it regularly? I think you should always give it regularly because its peak onset takes a while. It takes about an hour, so it doesn't lend itself to a breakthrough drug. It just doesn't have the quickest onset of action. This is oral, and the side effects are super rare, so you may as well just give it. And we've talked about, the misadventure with someone of lower weight, because it's a weight-based drug like all drugs, and you can go over the top if you have someone under 50 kilos. And the malnourished, classically the alcoholics, you have to be a bit thoughtful because, as you said, the toxicity comes from a metabolite, which is a really unfriendly one, and you need glutathione for that to mop up that toxic metabolite. And to get glutathione resynthesis, you need NADPH, which you guys don't have to remember this. This is anesthetic stuff, but the way you get NADPH is from glucose. So you need glucose to be able to get NADPH from I can't remember the pathway, the pentose something or other pathway. And then you need that to get glutathione. And if you don't have the glutathione, you get a lot of the toxic metabolite and you have a really bad time. In practice, what that means is we still pretty much give it to everyone, but in someone who's, going to have a potential for misadventure, low weight, malnourished, maybe if they're, an alcoholic, if they've got stable liver disease, we'll still give paracetamol. We'll just do a dose reduction or instead of QID, go TDS. So if you guys have rotations or do some placements at the Austin in your life, you'll see these liver cirrhotic patients with a history of, alcoholic liver disease getting a smaller dose of paracetamol and instead of QID, TDS. Unless they've got unstable, so active hepatitis or something, then they'll avoid it. So what would be your standard dose of paracetamol? It's, easy question. You guys can write it down. We'll make a bit of a list, and then one of you can give me your answer, and then I'll tell you mine. All right, who wants to tell me their paracetamol dose?
I think the standard for is 500 milligrams. That's just one tablet of paracetamol.
Yeah, you're right. 1 tablet of paracetamol. I would give 1 gram of paracetamol. I got on the next slide, my little thought bubble. 1 gram of paracetamol QID regularly to pretty much everyone. And anyone who's got pain, they get that because it's going to dose reduce the other drugs I'm using. It's going to definitely decrease the opioids, and it works on all types of pain. So it's thoughtless. I just give everyone a gram. You look at the literature, they're giving doses of 2 grams, sometimes 3 grams, a lot, and they're not running into trouble. But 1 gram QID as my baseline. And then as we we're talking about before, if I think someone's, at risk of misadventure, malnourished, alcoholic, they're of low weight, they've got some liver disease, I'll just dose reduce 750 TDS and still give it regularly. I just don't think it lends itself well to a breakthrough drug. It's just not quick enough. And it's a good baseline drug, very little harm. And it's a little bit like, it's a little bit noticeable when you're getting pain referrals and the paracetamol is not charted or it's their PRN, it's not being utilized. It's like the first thing you do, you just basically make it regular, have a chat to the patient about the benefits of using it. And then this little brain is just to remind me about something I reckon is interesting, but we've gone through it already. It's just the toxicity with paracetamol, and it's called NATQI, the metabolite. All right, non-steroidals. Who wants to have a
curiosity? Do you often get people presenting with like paracetamol toxicity, or does that happen often or at all? Because I know that it can be quite horrible if it does actually result in toxicity.
Yeah, it's super sore. I've done a lot of my placements at the Austin, so I have seen the paracetamol toxicities. The ED, physicians see them all over the place. The reason they really occur is because paracetamol is really the only drug that you can get off the shelf in large quantities. Like people on purpose take a lot of it. And the people who are generally doing it, people with eating disorders or people who do drink a lot of alcohol, they don't have a lot of glutathione, so there's a lot of risk. But, all the different mortality and morbidity meetings I've been to at different hospitals, a drug error resulting in a dupe, like paracetamol given twice, is not uncommon. The patient might take it before their surgery, a nurse might give it, the anaesthetist gives it into theatre, or they give it in theatre. The nurse afterwards doesn't look at the anaesthetic chart, or it hasn't been communicated very well for whatever reason. They get a double dose, and it's not good medicine, but it doesn't cause any harm. It's super safe, and there's been reports in pediatrics of dosing errors because it is weight based ultimately, and particularly with kids that are overweight, because it is dosed on ideal body weight, not actual body weight, and that has led to some pretty high doses inadvertently, and that's caused some problems. But adult population, even if you gave someone those at-risk patients a gram, you'll probably be all right.
So as long as you're not giving someone like a whole box, they'll be fine.
Yeah.
Yeah,
don't do it. I mean, it's still it's not good medicine. You don't want to make these duplication or calculation errors. Paracetamol is one you'll probably get away with, but the other one's not so much.
Jason, super quick. I'm really sorry. I think I must have missed it. Just what is the definition, or what do you mean when you refer to a breakthrough drug?
Oh, yeah, good question. So I call PRN drugs, so as requested drugs, breakthrough drugs. I think it's like better language, just because it reinforces for me and other people that it's a drug to take when you're going to do something active. So you've got your drugs at rest, but when you're going to do something active and you need more, or if your pain has gotten on top of you and you're struggling, then reach for the breakthrough drug. It's just a bit of language for me that commonly used by people, anaesthetists and pain specialists, just to give the drug a bit more respect, I think. Does that make sense?
Yeah, thank you.
Yeah, and then it sort of, you do see people using their PRN drugs or breakthrough drugs as regular, and I think it protects you a little bit against that. Like some people will see that they can take their oxynorm 4 hourly, so they take it 4 hourly, and then it just reinforces it's for that breakthrough pain or for some activity.
Great, thank you.
Yeah, good question. Thanks for pulling me up on that one. All right.
Everyone, just in the interest of time, we've got 10 minutes. We'll try to keep it to time, but we'll maybe go a bit over if people don't have pressing requirements. But maybe with the questions, put them in the chat so we keep going just to get all the content done. And we'll have time to stay in afterwards after we get all the kind of compulsory stuff done.
All right. Lahiri, do you want me to just go through some content on some of these drugs then?
Yeah, actually, that's a great idea.
Yeah. All right. Cool. Nice one. So non-steroidals, mechanism, you guys will know it's a COX inhibitor. So you stop the formation of your prostaglandins and prostacyclins and thromboxane. And, it works at the periphery. So it works well on the somatic pain, but it'll also work well on other pain types when inflammation's involved, which is, self-evident. But if you've just got neuropathic pain, if you've just got visceral pain, it's probably not going to do a lot. So it's a good one to recognize the type of pain you're dealing with. Good surrounding surgery, because you've still got somatic and the associated with it. It's got an even got a big bang for its buck as well. So it does reduce the opioids quite a bit in some of the studies, more so than paracetamol. And again, when we're giving IV, paracoxib, ketorolac, intra-op, we see those heart rate reductions, blood pressure drop, respiratory rate goes down. So when you're, doing an anesthetic while you're med students, if you've got an appropriate case and you ask the anaesthetist, can we see the effect of IV paracetamol or some IV non-steroidal? Watch the heart rate, watch the blood pressure, watch the respiratory rate. You'll see that they actually pack a good bang for their buck. Regular or PRN, so it's sort of appropriate for both, but again, it's got a pretty orally a later onset. So my practice is to give it regularly for 5 days, and then with food, just to avoid, being used inappropriately and to avoid some of the side effects associated with it, and to reduce my breakthrough opioids. Because if you're using paracetamol, ibuprofen regularly, you're starting from a good spot and you're not going to need as many opioids. You might just need, a breakthrough drug just for activity, and then they're going to be fine at rest. And then avoiding misadventure. The things to remember, I've got a bit of a list that I just check through when I'm putting everyone on non-steroidals. And then I go through this list and then I think, oh, no, maybe they're not appropriate. So you just want to check, do they have ulcers? Are they at risk of getting ulcers? So if they've had them before, if they're nil by mouth, I generally avoid them. If renal considerations, you guys would have heard of the triple whammy, because the prostaglandins are involved in your arterioles and in your glomeruli. So if you put them on a non-steroidal, they're already on an ACE inhibitor and they're on some furosemide and dehydrated, you might get a bit of a kidney injury. So I'm pretty thoughtful there. If someone's got, aspirin or non-steroidal sensitive asthma, I don't use it. But if they're, if I ask them, have you had ibuprofen before, then just go for it. Bleeding is an interesting one. You guys might not necessarily be giving pain relief to people who are actively bleeding. So you might not have to think about it. If you're a surgeon or you're, in a critical care setting, we'll go through it in a tick, but it does increase your risk of bleeding. And I'm thoughtful about when I give it, when someone's bleeding, about the timing. Pregnancy, does cause renal injury in the fetus. So it's generally avoided in pregnancy, but I have had an obstetrician, ask me to use it because they wanted to reduce the renal output of the baby, to reduce the amount of fluid they have, amniotic fluid. And then this is like the bit of nuance, is it's highly protein bound. So if you're giving it to someone on warfarin, you're going to displace the warfarin and the INR is going to go up. So that's like the bit of nuance, or the thing, like if you want to really make yourself a good prescriber, is to remember the highly protein bound.
And everyone will kind of get some rules as to how, like literally, I think I do what Jason does. Any ulcer, gastric ulcers, any kidney problems, any asthma, any bleeding tendencies, not pregnant, great, I'll prescribe it. And if anyone's got one of those things, I'll be hesitant, but you'll realize over time, you can sometimes in some situations, but as an intern, be very careful, and then you'll learn where you can do the exceptions for these rules.
Now, the brain on here was to remind me, like this is just a cool thing, but you guys might not find it that cool, but the non-steroidals are one of the few weak acids drugs. Like we have a lot of bases and it's a weak acid, and the consequence of that is it's got a pKa, which is the number that defines when it's going to be charged or uncharged, which is quite low. So the consequence of it being a weak acid, low pKa, is it's a charged drug, which means it doesn't go very far. It doesn't go into your brain. And in the setting of pain, we really like that because its abuse potential is really low. So it's a charged drug. It's a weak acid. There's not many weak acids, in pharmacology and medicine. So just a little special thing about it. And the other thing that makes that interesting is it gets absorbed in the gut, in the stomach, in that acidic environment where the pH drops below its pKa and makes it uncharged, and then it can get absorbed. It's just got this nice little cool little thing about it. Cool. So we'll just go through this quickly. It's just basically, it's a COX inhibitor, so it stops all these prostaglandin soup being synthesized, but it does shift the pathway to the leukotrienes. And the leukotrienes, they are bronchoconstrictors, so you can like upset someone with asthma. And we'll go on to the next slide. So we do have the COX-2 selective drugs versus the non-selective drugs. So basically it's helpful to have, in your arsenal, a couple of non-selective COX drugs. And it's nice to have, one that you can give orally and one that you can give IV. And it's nice to have some COX-2 selective drugs. And again, ones that you can give IV and one you can give orally. It's just nice to have that in your arsenal. The main thing I'll point out with the COX-2 is relates to bleeding. So if those right two boxes are the COX-2. So if you're blocking, and the left one is the COX-1, if you're blocking COX-1, you're going to block the formation of thromboxane on platelets. So when you're bleeding, if you guys can remember this, you'll have exposure of your damage to endothelium, exposure to cell contents, and then you'll get activation of platelets, and now you'll get thromboxane being produced, and then you end up getting activated platelets, fibrinogen, thrombin plaque, and thromboxane is really important to activate and aggregate those platelets. So if you're giving a non-steroidal, I always wait until the bleeding is controlled, and I'm happy that platelet plug has been formed. And once I'm happy, in my mind, there's a bit of a platelet plug, then I'll give my non-steroidal. So a little bit of timing if you're using non-steroidals in the context of bleeding is helpful, and it does increase bleeding risk. It's thought that COX-2, because it's not blocking COX-1, has less bleeding, and that's borne out in the evidence. COX-2 have less bleeding, and essentially all the other benefits of COX-2, because you can go through this diagram and work out the benefits. They're probably a little bit overblown. So we think COX-2 theoretically would cause less gastric issues because you're not, inhibiting your prostaglandins being produced by your goblet cells, and you're not inhibiting acid by your parietal cells in the gut. But in reality, when you compare them, people have the same amount of gastric irritation and ulceration. And potentially it's a little bit less bronchospasm with the COX-2 selective drugs. It does carry that, you guys would have heard it carries a higher MI risk, myocardial infarct risk, but the risk is probably about, 1 to 3 in 1,000 patients. And you could argue that pain is probably going to cause the same amount of risk and sympathetic drive leading to an MI. So in practice, we don't worry about it too much. So does anyone know any, some non-selective non-steroidals they could throw at me?
Ibuprofen?
Yeah, nice one. That's the one I use. There's other ones. And
diclofenac.
Yeah, diclofenac, nice one.
Naproxen?
Yeah, nice one. Yeah, good. And what about an IV non-steroidal, non-selective non-steroidal? You guys know any? I wouldn't have known any at this stage. It's good one to have in your back pocket. What about some COX selective ones? You guys know any?
Kieran mentioned celecoxib.
Oh yeah, nice one. Sure. Yeah, good, nice one. That's the one I use. And then anyone know any IV ones? That's all right. Well, let's go have a look at the next slide. And I've got my little thought bubble here. And this is basically keeping in mind, the potential harms. I give it to go through my checklist about who to avoid it in or who to be cautious in. Then I give it regularly. And I use ibuprofen, so 400 milligrams, giving it TDS with a meal for 5 days and then cease. So I'm a bit cautious going beyond 5 days because you start to get a bit worried about, gastric ulcers. And then if I really want it beyond that, then I'll move it to PRN, and I'll just be mindful that don't take it forever, have it with meals, don't take it as often. If it's someone who I want to use a non-steroidal on for longer than 5 days, even though the evidence hasn't borne it out, theoretically, probably better on your gut. So I'll use celecoxib. So that's our COX-2. And I use anywhere from 100 to 200 milligrams BD. And then I've got a couple of the IV options, which I just use once only. I don't want to keep the IV going because if someone's getting IV, it probably means 10 mil by mouth. And I'm a bit worried about their gut essentially. So I'll use the IV once only. It might be nil by mouth at the time, but my expectation is they're going to be going on to orals afterwards. So ketorolac is a COX non-selective, non-steroidal. Give IV 30 milligrams, and then I'll wait 6 hours and then go on to normal ibuprofen or celecoxib. And then paracoxib is my COX-2 IV option, and 40 milligrams IV. It acts a long time, so wait 12 hours. And then I'm giving those drugs in the context of bleeding once, in surgery, once the surgeon has hemostasis, and I'm happy that the platelets had time to activate and act and form a plug. Does that make sense? All right. Any questions about the non-steroidals before we jump on to the next drug?
Just quickly, Jason, why again do you take it with food?
Oh, it just protects your gut. So when you're eating, your gut's gonna basically have stuff in it. You'll have a bit more mucus in there. You'll make some acid. And it just gives your gut a bit of extra protection from getting an ulcer.
Great, thank you.
Not something that I've done because I don't use them for a long time, but I have seen that some people might give a PPI as well as a non-steroidal for a long time, but I try not to use them for a really long duration to start thinking about that.
Thank you.
No worries. Cool. All right, tramadol. Does anyone know why I've got Samuel L. and Samuel D. Jackson on this slide?
Enantiomers?
Yeah, nice one. So, sometimes we talk about enantiomers as being the good and the evil version. 2 Samuel L. Jacksons are better than 1. So tramadol is one where you've got 2 good enantiomers. It's a lovely drug in that regard. So you've got your D enantiomer and your L enantiomer. The D one gives you some serotonin action and some opioid, and the L, or the minus is the other term for it. It gives you some noradrenaline action. So you're hitting the pain pathway in lots of places, which is great. So you've got, some opioid, which acts at the brain, the spinal cord, and the brainstem. And you've got your serotonin, noradrenaline, which is acting at your, that descending pathway. What does that mean? You've got 30% noradrenaline action, 30% serotonergic action, and 30% opioid action. It's a great drug. Has anyone heard about the issues that come up with, potential issues that come up with metabolism and tramadol?
I think it's like how there's the heterogeneity in the population to do with the P450 pathway.
Yeah. So you've got poor metabolizers, intrametabolizers, extensive metabolizers, and ultra rapid of 2D6, which is metabolized by it. And there's a theoretical concern if you give it to an ultra metabolizer. Its metabolite, O-desmethyl tramadol, has 200 times the opioid action. So you'll get there's a theoretical concern you'll get a big sort of opioid effect with it. In practice, we generally don't worry about it too much. And there's a even stronger theoretical concern in a breastfeeding woman that she'll be a poor metabolizer. So she'll take lots of tramadol. It's lipophilic, so it goes into breast milk. The baby gets it. The baby might be an ultra rapid metabolizer, and the baby gets a whole bunch of opioid action from the metabolite. So it's nice to know about. If you don't remember it, probably doesn't matter. But it's a nice thing to be thoughtful of. Misadventure. So would you guys give it to someone who's taking an antidepressant? What do you guys have any thoughts on that?
If they're on, I'm just like ballparking here, it's really not my forte.
Yeah,
but if they're on like an SSRI and you're adding in essentially another serotonin inhibitor,
yes,
are you causing more issues?
Yeah, you're going to get a good bang for your buck of serotonin. And you know, in practice, it's a consideration when someone's on lots of serotonergic drugs, and it's a dose-dependent thing. So I've seen serotonin syndrome once in 8 years. It was someone who was on a lot of serotonergic drugs, anti-epileptics, some psychotic drugs, antidepressants, and then tramadol. It took a lot. And the other dose-dependent thing with the serotonin drugs is QTC prolongation. So it's common for anaesthetists and pain specialists to give tramadol with, you know, low to moderate doses of an antidepressant, essentially. And what I do to, you know, satisfy myself that it's safe is I do it in hospital. So I don't generally do it in the community, and I do it with an ECG and look for QTC prolongation because that's dose dependent as well. If I've got QTC prolongation, then I'm thinking they've got too much serotonin, and that's dangerous in its own right. And if they don't have that, I introduce the tramadol, check again with a QTC, you know, the next day, and it's fine. Then be comfortable prescribing it. But just because in those sort of patients who are on antidepressants, who are struggling with pain, it's a nice drug to still use. And it's a context where you could probably still use it safely. If someone's not on an antidepressant, then I just use it really readily. Like it acts multiple actions, works on multiple types of pain. The only downside is some people get really nauseated with it, and some people tolerate it perfect. Some people, you know, black and white, lots of nausea, lots of vomiting, and you just can't use it with them. So doses, do you guys want to have a think of your dose of tramadol?
Actually, Jason, just in the interest of time, I reckon we'll probably have to just go through the whole thing.
Yeah, no worries. That's fine. So tramadol IV per oral, you know, pretty much same bioavailability. So I just use it 50 to 100 QID per oral IV if I don't have the per oral option. And then we've had a chat about, you know, the SSRI co-prescription is I'll just do an ECG, check the QTC. If they're on a high dose, you know, not antidepressant, then I, you know, might not bother. But that's how I keep it safe. So my favorite drug, clonidine. So clonidine's got, you know, mechanism of action I just really like. It's alpha-2 agonist, but alpha-2 is presynaptic. So you've got your synapse. Most of the, you know, the receptors we think of are on the, you know, are on the receiving side of the synapse. But alpha-2 is presynaptic, and when it activates, it stops the vesicles being released. So it's this nice little spillover feedback mechanism. When you've got lots of noradrenaline in the cleft, some of it spills over and it stops the noradrenaline coming out. And we can hit that with clonidine. And the alpha-2 receptors, they're in the amygdala, they're in the brainstem, they're in the spinal cord, and they turn off pain. And because of those places where they act, they're an analgesic, they're anxiolysis, they cause a little bit of sedation, and they decrease your sympathetic drive. So it's a really nice combination of stuff in the setting of pain. And I find that clonidine is a silver bullet when you've got someone who's distressed with pain. So if, you know, you can throw heaps of opioids at them, you can give them more, you know, make sure they're on paracetamol, non-steroidal, you've got them on some tramadol, and then you're still not winning. But if you step back and you realize this person's quite, you know, distressed, they're anxious, they've got pain, then it seems to be like the drug that works. So I think it's a nice little drug. The the thing you have to be wary with it is going to lower your blood pressure. It's going to slow your heart rate down. And it's not really a drug to use regularly because you get a reflex effect when you stop it. You get hypertensive, blood pressure goes up, and you get tachycardic. So, no, I don't use it regularly, and I wouldn't encourage people unless they're going to be, around to wean the drug to use it regularly either. But I'm comfortable in appropriate doses, which I'll go through for interns to use it in the right context, which is, these patients, it's a back pocket drug where the patient is anxious, distressed, the other drugs aren't working. Blood pressure is fine, heart rate's fine to use it as a breakthrough drug. It's very readily a suggestion when you call the pain team and they recognize some distress is involved. So here's my doses for it. I make sure that the blood pressure is above 105, and then generally I'll start with 50 mics TDS as a breakthrough per oral. If they can't take anything per oral, then I'm dose reducing to 30 mics TDS IV. It's a nice drug. If you've got that situation, I encourage you to have a go with it. Just try not to use it regularly, or you'll probably have to guide, stopping the drug, calling the GP, giving instructions. It's not worth it. Any questions on clonidine? Cool, we'll move on. Yeah, it's a nice drug, really commonly used in pediatrics, commonly used by anaesthetists interop, and commonly used by people who know how to use it in the right context. So the gabapentins. So this is an orange slide. I made it orange because it's it's a drug to give with advice and thoughtfully. The main two reasons is because it's a bit of a sedative drug, leads to falls. You have to go pretty low and slow with it when you start it. So the benefit takes 2 weeks. So it's a drug to give thoughtfully and to have continuity of care with.
Hey Jason, just because we've run out of time now, what we might do, do you want to do a summary, and I'll cover gabapentinoids. We'll definitely do that in another one of the lectures. But we'll do a summary now and get any questions. Yeah,
nice one. So the summary pretty much is, guys, that my summary for this is really to have like that solid approach of set your expectations, think more about function instead of the pain scores so much. Know what your goals are, and then work out your rest pain, work out your active pain, work out what function you're trying to do, and then in your drug arsenal is basically and confidently use paracetamol, non-steroidals regularly. If you have a list of when not to use non-steroidals, and then for your breakthrough drugs, helps so much to remember tramadol, and it helps to remember clonidine, and then it'll mean that you're getting dose reductions in your opioids and you're not getting the harms of opioids, like obviously the addiction things, but also the immunosuppression, the concentration issues, the bone health, all the other issues with opioids. And you can end up, basically sending people home on paracetamol, non-steroidal, tramadol, and not even have to give them the opioid. Cool. Nice one. Do you guys have any questions?
Thank you so much, Jason. That was super helpful.
Oh, no worries. Yeah, I think I really strong believer, and it's helped me a lot, is to recognize the distressed patient and the anxious patient when the context of their pain involves emotion, is to recognize that, and without using drugs, is to in my communication and my empathy is to recognize that, and then also hit with some drugs as well.
Thanks, everyone. And as always, we'll make these slides available to you. So, I'll send that to Tamara, who will email it to everyone. I'll upload this lecture as it is on the YouTube channel, ABCs of Anaesthesia, for anyone who wants to go through it again or missed it. And otherwise, feel free to, any feedback at all, please just pass it along to us. If there's anything you wanted more of or less of or whatever it is, yeah, absolutely feel free to do it. And thanks very much for listening in. We'll stick around for the next few minutes if anyone's got any questions, and be happy to answer. But thank you very much. Thanks so much, Jason. Great presentation.